TopMedTalk.
Well, hello and welcome to TopMedTalk. I'm Desiree Chappell, and I'm joined by our editor-in-chief, Monty Mythen in London, England. Hello, Monty.
Hi, Desiree. Good to be here.
We thought we would go ahead and chat with one of our key partners, the Perioperative Quality Initiative, to discuss their recent published article in the journal Perioperative Medicine. Now, full disclosure, we are both authors on that paper.
We are, which I think, is that a first for us? I mean, we've spoken about a lot of papers, but I think this is the first one we're co-authors on it. We're privileged to be.
And we have the lead author as well as Tim Miller, who is heading up the Perioperative Quality Initiative with us today. So a fan fave on TopMedTalk, Dr. Tim Miller from Duke University. Hello, Tim.
Hi, Desiree. How are you?
I'm doing well. Tim, for our listeners, what is POQI? What is it that they do and the method that they use in these POQI conferences?
Yeah, so the Perioperative Quality Initiative was formed around 4 years ago now. Really, the idea was to do some consensus conferences around this emerging specialty of perioperative medicine. And the methodology is a sort of modified Delphi approach. Really, the idea is to get a group of experts in a room to debate a subject and come up with some consensus statements. And typically we have 2 to 4 different groups. And the way the conference will work is that individual work group will sit down in a room for an hour or two, come up with some key questions, some consensus statements, maybe some figures, the way they'd like to present their material. And then each group then goes back to the plenary session and they present this at the plenary. Each group takes a turn to present and they get criticized, discussion, ideas of how things could be improved. And basically over the course of the 2 or 3 day conference, you go back and forth between your small work groups and the plenary groups until you get consensus around concepts and statements that can be published. And the idea behind this particular POQI was that we thought, it's a good idea to revisit some physiological principles and try and make it practical for the everyday clinician. It's often a while since some of us have read about physiological principles, and some things have changed and evolved. So to try and do a sort of practical POQI style paper about physiological principles. So that was the idea, and Greg was kind enough to lead this group, and I think we come up with a very nice paper.
So like I said before, Greg and I and Nate Shapiro, I believe in Mike Grocott, right after the POQI conference, were able to sit down and do a deep dive and really get into some of the questions and the statements that we came up with, really into fluid responsiveness and venous capacitance, which was interesting. And I'll signpost our listeners. We will definitely be putting that in our show notes. So have a listen to that, because today I think we're going to try and do more of a brief skim of the article, and maybe not so much into the weeds of, one of our favorite topics, stressed and unstressed volumes and things, things like that. But I'll just ask you, Greg, for you personally, what were some of the big takeaways for you?
There's a couple of them that really that came out for me. The first one is that we need to begin thinking about more individualized fluid management. We've certainly learned more about the physiologic principles that go behind it, but we sort of want to think about them particularly for each individual. And we stated the goal in this case, in this paper, that the fluid therapy is really there to try and enable or normalize cellular function so that tissues and organs can function normally. And therefore, if you're a perioperative patient, you're going to prevent complications. If you're critically ill or acutely ill, it's going to help mitigate that or help the system to recover and repair. But then the second part of that, how do you choose the optimal fluid volume, is a very individualized decision. And part of the deep dive on venous capacitance and other things was really trying to understand that evolving concept and make sure that we can think about it for clinical relevance and how do we apply that in an individual patient.
Monty, we were looking at the paper earlier and talking about individualizing the patient's own fluid needs. And you were saying that you really enjoyed the tables from the article here.
Yeah, and I mean the diagrams are always fantastic, but I'd kind of forgotten with the passage of time when you do these things is that the amount of energy and effort that went into the terminology, because in trying to individualize the management, our bedside terminology is sometimes sloppy. You know, we confuse hydration with volume status, and then we are talking about total body water when we mean volume status. So I think those tables are really worth people having a look at closely and reconsidering when they use their language. I'm much more meticulous these days when I'm teaching about differentiating the concept of hydration, for example, total body water, and, you know, left ventricular end diastolic volume and the concept of responsiveness. So often you have to reread these papers to remind yourself how much good work was done on the days. Greg, you must be very proud of it.
There's two tables in there, one on terminology that's more physiologic and one that's more clinical. And part of the reason that they're there is that this Delphi group and the people working together realized as we were talking that we didn't all use the same language, that we were saying things and we didn't always mean the same thing when we were using terms. And so we realized that that was almost certainly common around the world, and we needed to put it down in text and make sure everyone's on the same page.
I think it's for people who are reading this manuscript. I mean, you could read the entire manuscript. I think it's 12 pages, but if you wanted to dip into it, there's some consensus statements at the start over the first couple of pages, just highlighting what we talked about during the conference. And then as Monty mentioned, there's those two very relevant tables and a number of figures. So even just looking at those, I think you could get a lot out of this manuscript just revisiting some of these key concepts.
And then there's the concept of fluid responsiveness, and there's a table one is the summary of the methods for predicting fluid responsiveness. And you know, it gives the method with a key reference, it gives the threshold levels and also the main limitations. And again, with the reference point of COVID-19, there's been a lot of discussion about this recently, because traditionally, more recently with, let's call it classical modern ARDS, the stiff lung, and the tendency for people to want to avoid fluid excess, there's been some nervousness, particularly in younger clinicians, in giving fluid. Whereas here we're seeing patients with possibly more compliant lungs where there's a more of a perfusion challenge than there is a ventilation challenge. And we've heard a lot talked about the passive leg raise, for example, where they can perform, there's a nice diagram in the paper, this passive leg raise to give a fluid bolus physiologically without giving extra fluid. And, you know, if the hemodynamics improve, and, oh, by the way, the saturations get better because you improve, you know, lung perfusion, then, you know, it's okay to go ahead and give a fluid bolus.
What's your take on that, Greg? As a pulmonologist, you must have a natural tendency to want to keep the lungs dry.
Yeah, it's one of the things that ARDS is one of those things that I've spent a good chunk of my career on, and particularly fluid management in ARDS has been a big part of what I've tried to study, either ways to prevent fluid from accumulating in the lungs or ways to try and accelerate drying out the lung and helping it to recover. And of all the things that we talk about, a lot of the things like Monty was just saying, ways to predict fluid responsiveness, the more that you can do that minimally invasively and without any risk to the patient is probably the easiest. And I've often joked in the past that the passive leg raise is the easiest because it just takes a medical student to stand at the bedside and raise the legs. But the diagram in the paper is really nice because it basically shows a patient going from a typical, what you'd see is a patient sitting with their head up and just reversing that. So the head goes down and the feet go up, and doing that's pretty simple. One of the caveats that I always tell people is you can't just rely on the blood pressure for that you really want to see stroke volume or cardiac output changing, because you could certainly make someone uncomfortable or do something else that raises blood pressure. And that's not necessarily a positive hemodynamic response. But from a critical care and an ARDS perspective, being able to test someone's fluid responsiveness without actually giving them fluids or putting them at risk of more pulmonary edema is incredibly valuable.
We know that, you know, the way that we're ventilating these patients, specifically if people are following kind of those ARDS recommendations and still doing, you know, high PEEP, low tidal volumes, those kind of things, you know, what are some of the limitations when we're looking at utilizing the dynamic parameters that we were mentioning in the paper and the passive leg raise and fluid challenges? Greg, do you want to take that one?
One of the things we realize is that dynamic measures of cardiac output and stroke volume are much more useful than static measures. So particularly years ago, we used to talk about using things like central venous pressure as maybe a measure of intravascular volume or of fluid responsiveness, and we realized that that's simply not the case. And so now we have many devices and techniques for more dynamic measures, meaning you can track over time stroke volume variation or pulse pressure variation and see those things change. And those can be pretty good not perfect, but pretty good predictors of whether someone will respond to a fluid challenge. And one of the things that we did, and its second page of the manuscript has all these summary recommendations. And part of what we did in the consensus process was try and nail down things that people could take home and use. So one of them, for instance, is how do we define fluid responsiveness and a fluid challenge? And we said that fluid responsiveness can be tested by administering 250 to 500 cc's of crystalloid, ideally in less than 15 minutes. So it's administered quickly enough that the patient can respond and you can make a measurement. And what you want to see is a 10 to 15% increase in stroke volume. And doing all those things by giving fluid is great because you can look at actual changes in cardiac output. But like we were just saying, if you do it with something like passive leg raise, where you're redistributing fluid from the lower legs up to the thorax, you're getting that same preload challenge, but you're not actually administering fluids that could cause problems for the patient who has ARDS or chronic kidney disease or some form of heart failure. The other one that I would talk about is we also talked about different ways to evaluate patients, and again, more individually. So we talked about sonographic evaluation of patients, looking at IVC distensibility and cardiac function. And particularly in the era of COVID-19, that's become more and more important because we use a lot of bedside ultrasound and even POCUS or point of care ultrasound. And for us, that's been incredibly valuable because we don't necessarily have or want to do additional procedures on patients. We try and particularly minimize aerosol generating procedures like bronchoscopy and airway procedures. But even other things, we try and group them all together and minimize healthcare worker exposure. But when you're in the room, you can do a quick ultrasound and get a very good sense of what's going on with the patient's cardiac function, which is not, unfortunately, probably is having some abnormality in 10 to 25% of COVID-19 patients in the ICU. But it also gives us a much better sense of their fluid status and whether they might respond to a fluid challenge.
Absolutely. The POQI work team is all open access, isn't it? You can go to the POQI website and download all the previous manuscripts, and the diagrams that go with it are deliberately open source. Is that correct?
Yeah, absolutely. It's available on the POQI website. Also, Perioperative Medicine Journal is an open access journal as well. So the manuscript is available on that website. And as you say, all the figures are owned by POQI and they're available for use if folks want to use them in other manuscripts or publications, etc. That's one of the things that we were very keen to do when we set up POQI.
And this is one of a pair of articles. Where's the other half?
The other one's on Professor Grocot's desk. But
I'm not calling anyone else.
It's in the final stages, and hopefully will be coming out soon.
Yeah,
we did have, which we'll post as well, another conversation with Tom Woodcock and Manu Malbrain. Monty did right after the conference, so that'll be a good one to kind of, if you want the teaser for the paper. Yeah,
it's the bit, there was some real mind-bending stuff in there about how traditional thoughts about how fluid gets in and out of the vessels in the body and the role of lymphatics. Very, very important stuff. So we look forward to getting that out there. Big shout out for Mike Grocott. Been very busy at the moment.
Yeah.
On, he's national TV.
National TV star over there in England. Well, gentlemen, thank you so much for joining us on TopMedTalk to discuss this really relevant piece on the fundamental concepts in perioperative fluid management, fluid responsiveness, and venous capacitance. I think that it will definitely be something that we can use as a resource going forward in the care of the COVID patient and hopefully just in everyday use. So thank you very much.
TopMedTalk.
And thank you for listening to TopMedTalk. If you want more information, you can go to topmedtalk.com. We have all of our podcasts there. You can also find us on social media, Twitter, Facebook, LinkedIn. And if you want to contact us with any questions or comments, contact at topmedtalk.com. Thanks so much for listening. Stay safe and stay well.